My name is Samia Mora. I'm a cardiologist at the Brigham and Women's Hospital and at Harvard Medical School. I'm an associate professor in Boston, Massachusetts. I just presented at the International Academy of Cardiology Annual Scientific Sessions 2015 in Vancouver. This is the 20th World Congress on Heart Disease. And the topic that I presented on was novel lipids and lipoprotein measures in cardiovascular prediction. The first question we addressed was about the role of measuring subfractions for atherogenic lipoproteins for predicting the risk of heart disease and stroke in individuals who have a low or naturally low LDL cholesterol level. And the second question was in individuals who go on a statin and achieve a low LDL cholesterol level from the statin, what measures of atherogenic lipoproteins or subfractions of lipoproteins may predict their risk. So for the first question, we addressed that in the Women's Health Study, a large population of about 27,000 women who were followed for 17 years. And we found that over that time period, even though the LDL cholesterol may have been high, in those women who had a lower non-HDL cholesterol, which is the sum of the total minus the HDL cholesterol. So the women who had a lower non-HDL cholesterol, they actually were at lower risk of future coronary events, such as heart attack. However, the women who had a low LDL cholesterol but had a high non-HDL cholesterol, they actually were at increased risk for coronary events during follow-up. These women, we call them discordant because even though their LDL cholesterol was low, their non-HDL cholesterol was high, or vice versa. We also looked for discordance between LDL cholesterol and another measure of atherogenic lipoproteins, which is ApoB. This is the sum of the atherogenic particles in our bloodstream. And similarly, with those women who had a low LDL cholesterol but a high ApoB, their risk tracked with the ApoB. So they were really, discordant women in terms of their lipid measurements. And also we did that with measuring LDL particle number, the number of LDL particles versus the LDL cholesterol. And we did the LDL particle measurement using nuclear magnetic resonance spectroscopy. And we found, again, similarly, that the discordant women, their risk tracked really with the discordantly high particle number measure, or ApoB, or non-HDL cholesterol, as opposed to the LDL cholesterol. The second question we aim to address is in the Jupiter trial, a trial of individuals who had a high level of C-reactive protein, a lot of inflammation, but their LDL cholesterol was actually naturally not elevated to start with. Their LDL cholesterol was less than 130. In fact, the median average LDL cholesterol at baseline was about 110. So in these individuals, they were randomized, half of them to get rosuvastatin, 20 milligrams a day, which is a high-intensity statin, versus placebo. And they were followed over a period of about 2 years on average, up to 5 years of follow-up. And in these individuals, we looked at, well, what does the on-treatment level of the atherogenic lipoproteins other than LDL cholesterol, how does that compare with predicting also risk of events during the follow-up? And what we found was, even though the LDL cholesterol was low, when you check to see does the baseline level of LDL cholesterol predict risk in these people, it did not predict risk. So we were surprised by that. However, their on-treatment level, so the individuals who were put on the statin, their on-treatment level of the LDL cholesterol, if that was high, that predicted risk of cardiovascular events. And similarly, we looked at a panel of atherogenic lipoprotein subfractions. These are different particles by different size and density, going all the way from the VLDL, or larger particles that are triglyceride enriched, all the way down to the IDL, intermediate density particles, LDL, low density particles, and then the HDL particles. We measured all of those subfractions using a technique called ion mobility. And with ion mobility, we found that the individuals who on the statin, they had a high level either of the VLDL, especially the smaller VLDL particles, or the LDL particles, in particular the large or medium-sized LDL particles. Those people were at increased risk for cardiovascular events. So we found that very interesting. We think it may relate to these individuals not having a very good statin response for whatever reason, and we need to find more better understanding of why these people are not really responding to the statin, because that's putting them at increased risk of having a heart attack or even a stroke during follow-up of up to 5 years. So the summary of take-home message that we discussed was that LDL cholesterol, just measuring the cholesterol in the LDL particle, may not be the best measure of either LDL or even atherogenic particles in our bloodstream. That there may be other measures, such as the number of particles, either measured by various techniques, such as nuclear magnetic resonance spectroscopy or ion mobility, or measured with an immunoassay test that's common in many hospitals called the ApoB, apolipoprotein B measurement, that these other measures may give us a better understanding of the risk that we may carry in our bloodstream with these particles.